4 years ago, the vision for these summits was to provide an opportunity for those who care and advocate for older and disabled people, fair access to Medicare, quality health care, and due process, to gather, network, and prepare, to form new and enhanced relationships, to work for affordable care, and unfortunately, just as often, against proposals that talk about preserving Medicare while shifting its cost to beneficiaries and its resources to private interests. The Center for Medicare Advocacy is a nonpartisan organization. I think it's important to make that clear, given the remarks that I have already made and others will be making today. But it is the Center for Medicare Advocacy. And I want to thank Bess and Brad and the rest of our board for forgetting that the organization's middle name is Medicare and last name is Advocacy. And they gave us the absolute support and even direction to do all that was necessary to speak out, to make sure that people continue to get health care and good quality health care coverage. And so we have that freedom to do that and direction from our board. And I want to have that understood as we go about the day. All of us are in this room because that's our work and that's our mission. And so today we proceed as allies in ensuring that healthcare stays alive and well in the years ahead, because it was under attack and it will be again. And it calls for us to be vigilant, to understand, as we'll hear, and I've already heard from Tricia, that we'll need to watch publicly announced regs. We'll need to watch about covert activities. None of this, it's just truth. We'll need to make sure that if that the marketplace isn't destabilized, that people don't help the Affordable Care Act explode. So to help us understand where we are and where we might be going, I'm really so pleased to introduce today's panel, Kathy Hurwitz, who's the Chief of Staff for one of the best members of the House, Jan Schakowsky, who tells us always that Kathy's the brains of the operation. You know she says that. Bob Berenson, who is such a wonderful resource for us all, because he helps us be able to put the facts and data and explanations behind our legal and advocacy arguments, and is going to talk to us about today in particular about quality, measuring, and that's and in part that you can't always equate the two, and that's so important for us as we understand and try to talk about healthcare in the years ahead. Sean Kavanaugh, thank you. Sean was it's so hard to put that in the past tense, the head of Medicare for the Centers for Medicare and Medicaid Services in the Obama administration following John Blum. Sean is a deep friend, was accessible, responded, did everything he could for older and disabled people and their families who depend on Medicare, and we thank you immensely for that work. Thank you. And finally, but never last, Bruce Vladeck, who is, among many things, a former administrator of CMS, then HCFA, who understands the necessity for all of these programs and will help us hear what we heard and direct us on our way for how we can do our advocacy. He's also a luminary of the Center for Medicare Advocacy and on the board of the Medicare Rights Center. Thank you for everything you do, Bruce. So with that, Kathy, I'd ask you to commence.
Oh, thank you. I get to get my Ouija board out and try to figure out what's coming next. Let me start by thanking the Center for Medicare Advocacy. I want to give a special shout out to David Lipschitz and Toby Edelman, who are a phenomenal representatives on the Hill. I can't tell you how important your work is. Our office relies on you for so much, And this month I signed up for Medicare, so I personally rely on you. So as does my mother, so we're very happy. I want to start where Tricia left off a little bit, and that is to talk about the victory we had on Friday. I had actually bet $5 that they were going to pull it together. Just because I've never, I'm glad I lost too. I would have been, I've never seen a situation where a party with the presidency and both houses of Congress have been so close and haven't been able to pull it off. And I think that that was for three reasons. The first is policy, and that's thanks to almost everybody in this room. Members paid close attention to what you told us about what was in the American Health Act. I mean, we paid attention. Everybody knew the figure 24 million. Everybody knew that. They knew about Medicaid expansion. They knew about the effects on the Everybody knew about what AARP calls the age tax, the increase in age rating, and what it means for the 50 to 64-year-olds. And one tip, if you go to the Hill, don't call them older Americans, because a lot of members of Congress are in that age range, and when we said it in the caucus, they all booed, so that was a little problem. They knew about the impacts of Medicaid block grants and per capita caps because they were hearing it from hospitals and the AMA and others. So it's not to say that everybody was a policy expert when we came out of this, but in some ways this was a gift to us because we got to re-educate people about what is really in the ACA. A lot of members of Congress and virtually all the staff people were not here when we passed it, so they didn't really know what was in it. So that was a really good opportunity. The stories, and I know a lot of you, that's the second thing, a lot of you helped us collect the stories about what it means to real people. That put a human face on it, and members of Congress, like everybody else, think about the people they meet and the effect of what they do on them. And then the third is advocacy. My boss has been an organizer for her whole life. She is walking around on cloud nine. She said she has never seen advocacy ever as we saw. It was the messengers, and I got to tell you, knowing that the Center for Medicare Advocacy, the Medicare Rights Center, AARP, Community Catalyst, people who folks trust were saying that this was a bad bill, meant a lot. The letters you signed mean a lot because, you know, surprise, surprise, some people don't trust politicians no matter what party they're in. So our being able to point to you was really, really important. The breadth of this was not just the normal people who are coming out on health care. It was everybody, including a 77-year-old woman who wrote to us, "I've never written to my member of Congress before, but I got to tell you, calls from and letters from people who have never contacted us." And then the result of that was this other second number. One number was 24 million. The other number that played a huge part was 17%. The Quinnipiac poll that came out and said 17% of Americans supported this bill. That meant a lot of people in both parties. In the Democratic Party, we felt confident. The Republican Party, a lot of people switched and said, this is not good for my district. I can't go with my party. I've got to go with my district. So all of that, thank you. So that's the good news. Then what comes next? I will tell you, I believe that the ideological view of changing the structure of Medicaid and Medicare and getting rid of the ACA is embedded. It's not going to go away. We are going to see them coming back and back and back. We saw it before the ACA. I remember when I worked for Ed Markey in the 80s, we had debates about per capita caps and block grants. We are going to continue to have it. So we have to be happy about our victory, but then we have to be prepared for more fights ahead. The good news is we have an educated populace who's ready to go. So what do we think? We do know that they are working even as we speak, to try to come up with another repeal bill. We don't see how they can do it. We don't see how they can. They've not reached out to Democrats, so we don't see how they can take the moderate Republicans and the Freedom Caucus and put it together. But be prepared, because, you know, their hope never dies, right? The second is what we call sabotage. We have already seen it, and in some ways we should take relief, because the ACA is stronger than people think. A lot of Standards & Poor's, the actuaries say it's doing better, it's stabilizing, but there have already been attempts to sabotage it. We saw the cost-sharing suit to take that money away from, not just from protecting low-income people in the exchange, but also helping insurance companies know they're going to be paid. We saw the attacks on funding for co-ops, and we lost our co-op in Illinois. We saw the Rubio Amendment, which blocked funding for risk corridors to help insurance companies. We've seen blocks on money for implementation. And then we've seen already in this administration, we're not going to enforce the individual mandates. There are other things that can happen regulatorily. If you saw appropriations yesterday, you saw Tom Price being questioned about what he intends to do. But things like changing essential health benefits, things like changing the actuarial value requirements so that more cost shifting gets onto the backs of individuals. Changes in essential community providers, who has to be included in the network. And then we see Medicaid waivers. And frankly, that scares us a lot. Illinois has a waiver request in there. Things like limits on lifetime limits on Medicaid benefits, work requirements, changes in essential health benefits. We don't know what's coming up. There are also legislative ways that they can come at us. One of which is we hit the debt ceiling. We have to raise the debt ceiling. We hope we're going to be able to have a clean raising of the debt ceiling. But there may be demands for changes in entitlements in order to get that done. The FY budget resolution, Jan fought to get on the budget committee so that she could be involved in shaping the budget, figuring out whether they're going to go after Medicare, Medicaid, even Social Security potentially, in order to make way for tax cuts, what the effect is on discretionary spending. Tax reform. Now, tax reform, you may not think that that's a healthcare issue, but the more money we lose in revenues, the more pressure there is to cut Medicare and Medicaid. So we're watching that. And then, of course, the appropriations bills. I mentioned that they've already used the appropriations process to try to undermine, sabotage the ACA, and we are going to continue to see that. So we have to keep our foot on the pedal. We have to keep doing what we're doing and doing more of it. But I also want to say there is a lot of discussion in Congress right now about not just defending, but coming up with our vision of what we can do to make things better. Improving the subsidies and cost sharing, providing a public option, dealing with the high cost of prescription drugs, adding benefits like dental, vision, and hearing to Medicare. So we're not just defending, we're also trying to figure out how we can make it better. And I just want to close again by saying it is so wonderful to have all of you and to be working with you and to know that we're in this together. So thank you very much.
I really appreciate. Can you hear me? No. This mic isn't working. I really appreciate the final point that we also want to think about today, and we will have a panel about improving. What can we do, not just defensively, but offensively, not like be offensive, but to improve things, to make things better. And we have been working with Kathy and others on the Hill, and will continue to do so. Thank you so much. Bob, did you want to speak from here? Yes.
Yep.
And you could advance your own.
I actually got slides here. I did the unconventional thing, but before I start, I just want to share this. I'm in a book club, and we've decided to read Crime and Punishment, which I'm sure many of you have read. Well, I'm not giving away a lot of the plot when I say that the old lady who plays a significant role was 50. Okay? So that's just to put this all in context. Now, let me see if this works there. Great. From volume to value, aspiration meets reality. And as you've heard from Kathy and Judy and others, you know, we've had a real divide politically, with Democrats trying to hold on to something very valuable and Republicans trying to undermine it. I'm going to talk about an area of health policy, in particular Medicare health policy, where the parties seem to be completely aligned. A couple of years ago, when the MACRA was passed, that stands for the Medicare Access and Chip Reauthorization Act, MACRA. In fact, it was hailed by some as an example of bipartisanship, as Congressman Boehner and Pelosi sort of had an event together to celebrate the passage. And I think it's a terrible idea, and I want to just spend a few minutes. But before I do that, I need to do a mea culpa. It was about 12, 13 years ago. Tim Jost, who many of you know or have read, he's quite prolific that way, hosted an event at Washington and Lee in which Bruce over here and I debated paying for quality. Is it a good idea? And Bruce took a very strong position that it's not a good idea. I was in the affirmative, and I remember saying it's a good idea if you do it right. Now, I should have known that it wasn't going to be done right, and it's turned out to not have been a good idea, and I've now gotten quite immersed, and in recent years have become sort of an activist protagonist, sort of arguing against it. So this is going to be about the current infatuation in health policy about this moving from volume to value. And I hope to do this quickly. I'm going to start with this. If you can't measure it, you can't manage it. Have people heard this phrase before? Well, or there was an article by a couple of well-respected policy guys. If something cannot be measured, it cannot be improved. That article called it a truism. What's a truism? Something that's so obvious you don't even have to say it. And it is attributed to W. Edwards Deming, who is well revered as a quality manager. He invented total quality management. He helped turn around the Japanese economy after World War II. He was a professor of management, a sort of shining light, now deceased. Deming said it must be right. The people who are sort of saying this argued if Deming said it, how can it has to be right. Now, I had a few hours a year and a half ago to ponder this phrase, and it made no sense to me. In my daily life, in my former life as a clinician, and as a policy person, I'm improving stuff all the time that I'm not measuring. Now, there are some things that I have to measure. If you want to monitor and help control a patient's blood pressure, you have to measure their blood pressure. But there are a lot of other things you don't measure. So I was curious about this phrase and why Deming would say it. Here's what Deming actually wrote. It is wrong to suppose that if you can't measure it, you can't manage it, a costly myth. In fact, it's quite something. There are quotes that are taken out of context. This isn't taken out of context. This is a misquote. And someday, if I have another few hours free, I'll try to get to the roots of who completely distorted Dr. Deming's views. In fact, I wound up reading one of his books, looked at the other one. He didn't believe this at all. The most important figures one needs for management are unknown or unknowable, but successful management must nevertheless take account of them. Management by numerical goal is an attempt to manage without knowledge of what to do. It's management by fear. So the phrase could be true, but Deming certainly didn't believe it. So in fact, there have developed dueling slogans. This one, if you can't measure it, you can't manage it, basically. And then somebody found this very clever rejoinder. Not everything that can be counted counts, and not everything that counts can be counted. And everybody sort of attributed this to Albert Einstein. And in fact, if you Google this phrase, you will see at least 24 images of Professor Einstein at his blackboard writing this on his blackboard, only he never said it. It was a guy named William Bruce Cameron writing in the 60s after Einstein had died, actually came up with this clever line. So my conclusion is, no wonder we don't do evidence-based policy making. We can't even get quotes right. So this sort of goes to sort of the genesis of this idea that we have to measure. I have this sort of 1-hour presentation. I'm boiling it down into 3 bullets. There are 3 major problems with pay for performance, and that is half of what's in MACRA. It's called MIPS, which I'll get to in a second, the merit incentive-based payment system. It's conceptually flawed, at least for professionals, physicians and other health professionals, because of crowding out of intrinsic motivation that all professionals have. And behavioral economists in recent years have actually stepped up to actually make this point more clearly, that if in fact you are measuring and rewarding, importantly rewarding financially particular aspects of care, you may get an overall decrement by compromising the intrinsic motivation that professionals have to do a good job. For hospitals, it may be a little more complicated. The question, I guess it's if you believe Mitt Romney, corporations are people, my friend. It's at least conceivable that hospitals would react somewhat differently than professionals would, although the data, which I'll get to in a second, doesn't suggest it works there either. Relevant and accurate measurement is difficult and very costly. Larry Castellino and colleagues did a study published in Health Affairs a year or 2 ago, calculated conservatively that physician practices spend $15.4 billion producing the data to respond to both private payers, but Medicare is in the lead in this pay-for-performance stuff. Now, if you add what the hospitals are doing, what the nursing homes are doing, what the insured, all the payers are doing, and then this new entity called the Measurement Industrial Complex, all of the people whose jobs depend on this measurement enterprise, conservatively, I would think we're spending $40 to $50 billion a year measuring stuff. And are we getting that kind of worthwhile value? I mean, the title was, all the rhetoric is, this is how we're going to get value. And there are huge, just operational problems with measure gaps. We can't measure, I'm going to talk specifically about docs now, what most physicians, what we want them to mostly do. Measurement comes from claims data. Claims data can give you some information, but it doesn't tell you, for example, that the image a radiologist has interpreted was correctly interpreted, or a pathologist, or all the things that we want primary care physicians to do, and then we measure what they do in prevention. Not unimportant, but the idea that it gives some sort of global assessment of a doctor's value, which is what's in MACRA, is just flawed. And the MACRA legislation says to CMS, go fill the data gaps. Well, people have been trying to fill these data gaps for 2 decades. This is not a new challenge. And it's not easy. In fact, in some areas, like misdiagnosis, I would say it's virtually impossible. There's no doctor who puts on a claim form, I'm putting a diagnosis here, but it's incorrect. It's very challenging to actually measure what matters. We want to move towards outcomes, and that has all sorts of measurement challenges. So as a result, we're measuring processes of care. Again, it's exactly what organizations should be doing internally, but it's not, I think, useful particularly for the public or for public policy. And then more practically, we now have 10 years or more of evidence coming in. And the accumulating evidence on pay for performance across more than a dozen OECD countries, there was an article published in a journal Health Policy, finds no evidence that it actually meets the, quote, compelling logic. That was language used in an initial New England Journal editorial, compelling logic. actually, when you sort of take into this sort of view that maybe it actually undermines intrinsic motivation, I'm not sure there's compelling logic. But the evidence doesn't show that it works. Even in the UK, which gave primary care doctors a 25% bonus for hitting measures of primary care activities, the policymakers there don't think it was money well spent, or at least there's mixed views on that. So that's my conclusion, is finding this quote: "The food here is terrible in such small portions." We had a program that used small financial incentives on physicians, up to about 2%. Half the docs in the country weren't producing the data because the docs didn't think it was important to. They didn't give much credence to the measures. Now under MACRA, it was actually under previous legislation, but reaffirmed in MACRA, that's going to go up to 9% potential loss, or 9% or even more potential gain based on the performance on 6 measures or something like, I mean, it's more complicated than that. So we've taken something that doesn't work, and we've now increased the portion size so that everybody has to respond to it. So now specifically, and I'll try to be quick, the relevance here, what MACRA got right. Now this was that legislation that passed 2 years ago. Repealing the SGR, this was the mechanism that was going to cut physician fees by over 20%. That should have been done away with, and it was. They've included clinical practice improvement, which strikes me as something worthwhile, asking physicians to actually spend part of their time defining and trying to improve particularly important aspects of care, not just seeing patients one after another as they come through, and promoting alternative payment models. That's also in MACRA, and I think that's a worthy thing to be trying to do. Not easy, but I think that deserves support, not this pay-for-performance stuff. My number of lines for what MACRA got wrong is much longer. It is numbingly complex and threatens small practices, because if you're a small practice, you can't produce a lot of this data, and it's costly to. The timelines are overly ambitious. And here's the one that I think we were just chatting before coming up here as to what is going to lead to the backlash against MACRA. I think this one might. The legislation says that every doctor who has a certain amount of spending in Medicare is going to be given a rating, or a ranking, actually. And the idea that the federal government should be rating every doctor is, I mean, I'm a liberal Democrat. We're among friends here. I don't think that's what we should be doing. And I'm amazed that all the Republican docs supported legislation which would be putting a rating on every individual physician. And the complex, and this is the most important thing, I bold-faced it, the complex of public reporting, pay for performance, alternative payment model demonstrations diverts attention from other, I would argue, more important opportunities to improve value for beneficiaries and for taxpayers, such as addressing this quality problem of diagnostic errors. I was on an Institute of Medicine panel a couple years ago. We produced a report which documented that something like 5 to 15% of interactions with the healthcare system result in a misdiagnosis or a missed diagnosis or a delayed diagnosis, that to the detriment of the patient. We can't measure those. A couple years ago, I was at a conference for the Society to Improve Diagnosis in Medicine, and there was a chief medical officer from a Midwestern hospital. And I said, "Why are you here? Your hospital's ratings by Medicare don't depend on anything that's going on at this conference." And he said, "Yeah, that's what my CEO asked me." He decided it was an important issue, even though hospitals don't benefit or lose by what's going on inside their walls related to diagnosis accuracy. So we have become so into measurement and requirements of measurement that it sort of takes up all of the oxygen. There's not a lot of room left to deal with, let's say, diagnosis errors. Or by increasing the supply of primary care clinicians and geriatricians. So we have an aging population, and there's a handful of geriatricians for the country. The Affordable Care Act created a workforce commission. It has had 2 terms and has never met. There was never an appropriation. Commissioners have been appointed and reappointed to this commission. Nothing happens. We're not increasing the infrastructure of the professionals able to care for an aging population, but we're going to measure a handful of measures. And nobody's even talking about that as a public policy issue. And we could go after, we could identify many other issues that would involve value but don't involve measurement. Very quickly, I give CMS, and Sean, if you were part of it, I assume you were, credit for the final rule exempting nearly 400,000 clinicians from small practices because they don't meet a threshold of Medicare revenues. That had the real danger of immediately moving the rest of the doctors to employment, either by largely by hospitals, but by other kinds of organizations. I think that would be a mistake. CMS understood that. And most importantly, buying time so that policymakers, both in Congress and the new administration, can reconsider what they have wrought. I think there is going to be a backlash to this. What I've suggested is that the whole concept of this pay for performance is wrong. Now, I'm going to finish with alternative payment models and just make a couple of points. I am, just for full disclosure, there's something that Macro created called the Physician-Focused, let me see if I get this right, Physician-Focused Payment Model Technical Advisory Committee, called PTAC. So I'm not speaking on their behalf. I'm a member of this, and we're supposed to be beating the bushes especially for specialists to have new payment models. I am the first to suggest that fee-for-service is not the ideal payment model. I'm reminded of this terrific line that Jamie Robinson wrote in a Milbank article a while back, said there are 3 ways to pay physicians. Some are good, some are bad. The 3 worst are fee-for-service, salary, and capitation. Those are the 3 sort of basic ones. What this organization did was array the payment models on a spectrum with the implication that as you move from left to right, you get more value. And I think that's wrong. I mean, fee-for-service is on the left, population-based payment, which we used to call capitation, is on the right, and then there's all these intermediary steps. And I would just make a few points. It emphasizes the theoretical incentives and payment methods, mostly ignoring the design and operational issues that working together actually influence physician behavior. It's sort of, do we have the incentives right? But a lot of this stuff can't really be implemented. It assumes that value derives only from use of quality measures and financial risk-bearing, which I think is oversimplistic. It arrayed, I just gave you the simple slide, 28 potential payment methods in a classification system. But the point I'm also emphasizing here is that any payment method can be designed to produce more or less value, and that includes classic fee-for-service. So if we have a fee schedule, which we have in Medicare, that pays too much for procedures and tests and not enough time for time spent with patients or about patients, you will get too many procedures and tests. You will get too many specialists. You will get orthopedists making 2.5 times the income of family physicians. That's not inevitable. That could be changed, and fee-for-service could function with a lot more value. So I'm sort of challenging sort of this notion that we have to do that. And I put this up just to say that even a fee schedule, which gets derided as that's volume-based payment, has advantages, it has disadvantages. But to just prove my bona fides, because some people think I'm sort of this Neanderthal defender of fee-for-service, I put up this quote from George Bernard Shaw. I actually quoted this in an article I wrote 30 years ago, and I think it's worth repeating. That any sane nation, having observed that you could provide for the supply of bread by giving bakers a pecuniary interest in baking for you, should go on to give a surgeon a pecuniary interest in cutting off your leg, is enough to make one despair of political humanity. When I wrote that in a New Republic article, I had a friend come and say, well, you did a great job tearing down fee-for-service. What's your alternative? And now, 30 years later, we're still looking for the alternative. So on that notion, I guess I'm going to conclude. Healthcare is complicated. Thank you very much.
Yes, it is, and we're so lucky to have you on our side. Imagine if he wasn't. Thank you so much, Bob. Sean?
Thanks, Judy. And I guess I'll use my time here to try to bridge what Kathy was saying and what Bob was just saying. Bob concluded by saying healthcare is complicated, and he's right. And I think many of us who've been involved in healthcare payment would drill down on that and say healthcare payment is complicated, despite our best efforts to claim that it's simple and that there are rubrics that tell you which way we should go. I haven't been in this business as long as Bruce and Bob, but I'm getting up there. And the longer I've been in, the more humble I am about payment, even though it's been my whole career, about knowing what the right form and method of payment is. But it's going to be important for the reasons I'll mention. I think Kathy did a nice job of telling us why the story that just played out ended the way it did. And it was because there was a story, there was a compelling story on the right side of all these issues. I think we're going to need to collectively start thinking, what is the story for Medicare? Because they will turn to Medicare, and by they I mean Congress. There's been a lull since the MACRA, but just as a reminder, from 2015, if you look at last year's trustees report, they're forecasting that from 2015 to 2025, so a decade that we're already well into, Medicare spending will double in total from 600 and some billion to 1.2, almost 1.3 trillion. And that's driven by several factors, clearly driven by the aging of the population. As more, I think the Medicare population over that period grows by a third. But also, and you should take this with a grain of salt, anything that goes out, projections that far out, but they're predicting that, Bob mentioned that per capita Medicare costs are actually almost flat, 1 to 2% per year. The actuaries are predicting that that will be reversed. We'll be back up in the 5% growth per year. And when you compound the population growth and the per capita growth, you get a doubling of the program. And I think you'll get the budget folks, the people who believe in entitlement reform and all those folks, whether it's this year, next year, or it'll be sometime soon that will turn their sights to Medicare. And we need the compelling story of why beneficiaries shouldn't be the ones to suffer. And I think that's how you end up with things like MACRA, which is when you're on the Hill and you've got this budget situation of the doubling of the Medicare budget, well, what can you do? You can cut benefits to Medicare beneficiaries. No member, well, many members don't want to do that. Cut payments to providers, which has been, the one thing about cutting payments to providers is, unlike every other payment methodology, it's evidence-based. It's been proven to actually save money. I turn to Bruce because we're both former rate setters. But that's not fun for members of Congress to cut payment rates. Raise revenues. If anything, this Congress just recently tried to reduce the revenues flowing into the HI Trust Fund. But I think the reason you see MACRA having bipartisan support is because it offers the hope that there's a payment miracle that everybody intuitively believes in. Bob mentioned there's a compelling logic, and then he disproved the compelling logic. I actually think it's not a compelling logic so much as a compelling feeling that you should be paying for value, and that intuitively feels right to members of Congress, and therefore alternative payment models and paying for value, if not painless, is a virtuous way to address the budget crisis. Budget crisis I use in quotes because I don't believe in the budget crisis related to Medicare. But I think that's why you see all this activity, that they're trying to find a third way. And again, I've dedicated my life to trying to find the third way. I think the difference is I've come 25 years later to have a great list of questions and no answers, whereas they need answers immediately. And that's how you end up with something like MACRA. I don't disagree, even though I was complicit, not in the law, but in much of the implementation, I was complicit in both the advantages and disadvantages that Bob listed.
I thought just the advantages were yours.
Yeah, well, you've read my resume, clearly. But so for a community like us today, I think, and again, I don't have the answers, but I think the question for us is, okay, if that's the situation we're facing going forward, what is the beneficiary's investment in this? And I think Bob makes a pretty compelling case that the beneficiary has a big stake in it, because if you get payment wrong and it drives a behavior that's not optimal, the trust fund might suffer, but clearly the beneficiary might suffer as well. So we should, as much as it sounds like not a beneficiary issue, I think payment is very much a beneficiary issue and will drive, in both positive and negative ways, the type of care that people, the type of health care that people we all care about will receive. Bob mentioned if you do it right, which is the ultimate caveat, like it's like our whole careers, right? If you do it right, everything good will happen. But I think the delivery system, and I think where we have some agreement is that while the pay for value, which was sort of the middle of those rubric, has some real problems, there are alternative payment models, not solely those that transfer risk to providers, but a number of alternative payment models that do hold out genuine hope, both to improve care that beneficiaries receive, but also to help with this growth in spending. So just that. The other thing I wanted to talk about briefly, because it's, oh, I'm sorry, before I move on to Part D. So there will be a backlash to MACRA. And that is the context. We need our stories together, and we need to know what is the beneficiaries, when the provider backlash occurs, what's the role of the beneficiary voice in that backlash? Because Congress will have to react to the backlash. I actually thought the backlash was going to come differently, which is, there's two aspects to the backlash. One is the complexity that Bob mentioned, which is all these physicians are like, oh, damn, I have to do all this reporting. Because as he correctly pointed out, the vast majority of physicians didn't report anything under the previous value-based modifier and paid a 2 to 4% penalty. But as the stakes get greater, they'll have to deal with the complexity. They'll have to deal with the reality of being ranked. So the previous system called the value-based modifier didn't actually rank most physicians. The vast majority of physicians in the country we just declared average. And only those who were very much outliers did we have any confidence in saying too high, low quality, or very good and high quality. MACRA doesn't allow that. All the physicians will be on a spectrum and will know what the systems rank them as. I think there'll be a backlash to that. But equally compelling, and the actuaries said this in day one, is MACRA is set up so some physicians benefit, some physicians don't, but there's for the average physician over a 10-year period, there's almost no incremental increase to their fee schedule payments. And the actuary said that's not sustainable over a 10-year period. And so I think you'll have a backlash to that. So I think as all these forces roil, you'll see the physician community go back to the Hill and say either repeal or replace, excuse me for using that. And I think it's incumbent on all of us to say beneficiaries need a seat at that table, but we need the story we want to tell in that context, and it's something we need to spend some time thinking about. Neither of you've mentioned this, but I've been on a hobby horse recently about Part D drug expenses. And if you'll bear with me, just quickly go back 10 or 11 years when the Part D benefit was created. As you know, some members of Congress very much didn't want it to be a fee-for-service CMS-administered program, so they said we're going to pay plans to administer it. At the time, there was no such thing as a Part D drug benefit-only plan. So they were very careful to get plans into the business by reducing the risk to the plans in two ways. One, there's risk sharing, but also they set up the benefit that the catastrophic expenses associated with any beneficiary would largely be borne by the federal government, and the plans wouldn't be at risk for it. Well, you scroll forward 10 years, and what's happened? Almost the vast majority of the spending and all the growth in spending in Part D is in that catastrophic phase. So the part that the plans are taking risk for is actually become a minority of Part D spending. So one, the debate of whether Medicare should negotiate for drug prices or the plans should, sadly, we're in a third place right now where the plans are, but they're only doing a small piece of it because they're not at risk for most of it. So no one is really managing the drug benefit from that perspective. The second is, and this is, I haven't fully figured out this story, but there was a report that came out last year from Milliman, big consulting firm, for the AIDS Institute, where they showed that, or purported to show that Part D plans can do better by accepting very high prices on drugs with rebates, even if the net of that is higher than a lower price, lower rebate, because it shifts more of the cost to the federal government and out of their direct subsidy. So, I think pharma contests that, but there's clearly something to this because we have seen that behavior of more and more high price and more rebates. So I've been worrying, the context again is Medicare costs doubling over the next 10 years, and according to the actuaries, Part D being the biggest component of that. So, or the fastest growing component, not the biggest. So we have a benefit that was designed, I think, appropriately for its time, but our age has caught up with it, and plans have figured out how to, I don't want to say manipulate it, but I don't think the taxpayer and the beneficiary's interests are being represented in the management of the Part D benefit. And I think that's contributing to a lot of this. And I think there's many layers to this, and it's not getting attention. It's really boiled down to should Medicare negotiate or should the plans negotiate, and not whether the structure of the benefit works. My last comment will be, all this risk sharing where the federal government's taking on the risk made sense when the industry didn't exist. But if you look at who Part D plans are now, these are big, well-capitalized multinational corporations that we're protecting from financial risk. Maybe appropriate 10, 11 years ago, but I think less and less appropriate now. So the final thing I'll say, and I think it's relevant to my Part D comments, because I talked all about the trust fund and the Part D plans, and this is something that is a problem that CM directors inevitably fall into, which is when you're in my previous job, you're dealing all day with hospitals, doctors, managed care plans, Part D plans, drug manufacturers. And then, if Judy calls, one meeting out of the month is about beneficiaries. And Judy, I give, and CMA, an enormous amount of credit. There are obviously AARP, Medicare Rights Center, but the list is pretty short, and it's a lot shorter than the list of providers that came in and drove an agenda, meaning CMS has its own agenda, but it also has to be reactive. We have to react to what Congress says. We have to react to what all these stakeholders say. And to the degree that the stakeholders are providers constantly, that becomes the agenda of the agency. And so just want to reinforce the need for a strong beneficiary voice and a well-informed beneficiary voice. I mean, I think Judy rightly acknowledged Bob for providing tons of data and factual basis for the beneficiaries to be advocates. But I think this industry, you mentioned the measurement industry, I think the beneficiary industry is long overdue for growth spurt. I don't know how you get that to happen, but I just wanted to say from my perspective, you've done, pound for pound, done a great job, but need to get bigger and stronger. So with that, I'll turn it to Bruce.
Thank you.
I have a postcard on my desk of a drawing of David and Goliath that a colleague gave me many, many years ago. And I hope the funders in the room will recognize that pound for pound we do all we can, but it's a really big struggle. And I want to recognize that when we first met with Sean, he did mention that very point, that you mostly were sitting with providers. And I thank you because your door was, and email was always open to us. And that's, you know, we know we can't always, I think we know the music and the words, as I often say it to my crew, but we can't always, you can't always get what you want. It's a great song, but you can try sometimes, you know, and you can be persistent. And and know what you're talking about. And Bruce, I know you've heard me say this before, but I recall when I met in your office with a bunch of the old guard who's here today, many years ago. You had been in office for about, you'll know, but 6 months, probably more, and you said that you had spent that time figuring out the vision and purpose of HCFA, and you said that you realized the primary customer was the beneficiary. And I have to tell you, under my breath, I thought to myself, no, duh. But you know what? You knew that. You acted that way. And I think that there currently, I'm very much afraid that the powers that be at CMS and at HHS don't understand that all these programs were set up for the people, not for the provider and the provider industrial complex that has occurred. So Bruce, thank you for that, and on with your comments.
Yeah. Thank you, Judy. I was telling Sean earlier, now that I am a Medicare beneficiary, and I feel some of those issues even more strongly than I did in the past, especially after my first claim was denied. But
Hope you frame that.
it actually wasn't Medicare's fault; it was the previous carrier's fault. But and I am really pleased to continue this relationship. And I'm really sort of my brain hurts at the moment because just in the last 45, 50 minutes, I have gotten, and I try to think I pay attention to this stuff reasonably well, a primer in some of the most important issues going on around the ACA from Kathy and from Medicare with such sort of sophistication and wisdom that I'm really glad that I don't have to sort of digest it all, because I'll be thinking about it for quite a while. And in that regard, I really want to, I mean, this is all great stuff, and I mean, nothing more I'd love to talk about than alternative payment models, but it's hard. It's really complicated. And I don't have to do that anymore. So what I'd like to do instead, very briefly, is just sort of take the real sort of big picture 40, 50,000 feet view. And I think probably the best way to introduce that subject is to say, like all of us, I think, every morning and before I go to bed, I check the news feeds on my phone, or I open the paper with a sense of dread, not so much about stuff I'm already totally agitated about, but what new thing is going to happen and turn up these days. And I really, actually, until I watched Colbert last night, I didn't really care that much about internet privacy, and now I'm in a total panic about that. But as I was following all the discussions about the new administration and the budget and the repeal and replace and so on and so forth, there was one little sort of sub-theme that kept sort of popping up and then sort of disappearing because nobody was paying that much attention to it yet. But to me, every alarm bell and red light in my psyche was going off 100%. And that is people like the Committee for Responsible Federal Budget and the Peterson Foundation and so on and so forth are back at it already. We know that Paul Ryan's major ambition in life is to gut the Medicare program. He's not sure he'll live long enough to gut Social Security. He'd like to do that as well. The good news, of course, of the last week is after years of lots and lots of work by lots and lots of people, and here I'd give the Kaiser Foundation a lot of credit, we have normalized, legitimated the Medicaid program to the point of view where it's much harder to kill than it was in the past. And not only do more people, of course, in the United States depend on Medicaid for health care coverage than on Medicare, but almost 15 million Medicare beneficiaries depend on Medicaid for critical parts of their health care coverage as well. But if you take sort of, you know, the arc of history, the most effective profit of the last 30, 40 years in public policy at the macro scale has been probably the most, well, it's hard to say who most reprehensible of all these guys is, but Grover Norquist, who said we're going to starve the beast. And you go back, I'm old enough to remember, and I've had a lot of deja vu sense about it in recent months, the first Reagan budget. And ever since then, with a few interruptions, far too few during the Clinton administration, frankly, a few more in the first 2 years of the Obama administration, we have been on this course. You're going to reduce government revenues. You're going to start by picking off the so-called domestic discretionary programs until there are fewer and fewer left. Then you're going to go after the entitlements. We've already killed AFDC. We've already gutted workers' comp in a variety of ways. And the big three that are left are Medicare, Medicaid, and Social Security. And if you don't think they're right in the middle of the crosshairs, or the people who are writing the ideological script for this Congress and this administration, you're wrong, because that's the long-term plan. And they've made a frighteningly large amount of progress with it over the last 35, what is it? Can't even do the arithmetic anymore, 35 years. Now, just as a little bit of a digression, the last few years I've found myself in the minority position on a whole variety of debates that have sort of been Medicaid specific, having to do with the so-called social determinants of health and their relationship to Medicaid expenditures and providing the necessary services to reduce medical utilization by Medicaid beneficiaries. And the one that got me on the nightly news hour on PBS was an argument I had with Mitch Katz, who's the health director in Los Angeles County and a wonderful, superb public health leader and administrator who's been preoccupied with the problem of all the street homeless in Los Angeles on Skid Row, and who tend to be very heavy, very expensive emergency room users, and who worked with a couple of local agencies to develop supportive housing for some number of those homeless people. And lo and behold, once the homeless people were no longer homeless and were getting appropriate social services as well, they stopped using the emergency room so much, in part because they had other places to get their problems dealt with, in part because they were healthier. And Medicaid saved a lot of money, and you could even argue that the total cost of providing the housing, the social services, and the reduced Medicaid was less than the pure Medicaid cost would have in the past. So they applied for a waiver to CMS to cover supportive housing and so on and so forth. And CMS said, nope, can't do it. It's not permissible under the statute. And of course, they got beat up in the press and so on and so forth. And I think was probably the only person not in CMS who was prepared to defend that position on television. So I got up to play that role. But the fact is that we've already Medicaidized payment for every human service that you can possibly get under the language of the statute. And the reason we've done that is that we've stopped funding every other human service. So the advocates and the people trying to provide services have been in this catch-22 in which, on the one hand, in order to continue to pay for services, we've put them under Medicaid. At the same time, we've driven out the available funds to pay for all those other services. And the fact of the matter is, when you provide social services, when you provide counseling, when you provide housing, when you provide nutrition services through a healthcare provider, it's going to cost you a third more than if you do it through a social service agency than used to doing it. So it's wasteful, but that's what we've been stuck in. And I think that while in the short term, what Mitch is doing makes sense. In the long term, that's another nail in the Medicaid coffin for the budgeteers and the balanced budget and so forth. All the way, and I think you all know this, but there's a critical thing we don't talk about enough as advocates, and I think we have to figure out how to start talking about it. And that is the underlying problem we have here is that if you're going to have a minimally humane society that at the same time supports a military establishment to be the world's principal superpower, you can't finance that with the federal revenues at 18 or 19% of GDP. The arithmetic will never work. It can't work. And so we have to say that if we want to have a more humane society, we have to pay for it. And we have to begin to think about how to tell this story and how to make the narrative that if we're going to have improved, which we need, Medicare and Social Security and Medicaid programs 20 years from now, 25 years from now, we've got to start now with real tax reform, which includes getting the people in that 1% and the people in that 5% to pay half on average of what they would pay if they lived in Northern Europe, for example. And we have to clean up the corporate tax code so that General Electric, to take a random example, actually pays corporate income taxes in the United States. And the one thing that I have a particular hobby horse on that we'll never get anywhere on because we've lost the story, but I've just been reading a couple of things in recent days about how if you go back to the original purposes of the Founding Fathers and read Jefferson or Madison, what you're going to be reminded of is there is nothing that made more sense to the Founding Fathers than an estate tax, because they were okay with unequal distribution of income. They weren't okay with intergenerational transfers of wealth, because that's what they were trying to overcome with the Revolution. So we've got to start getting those stories out there, because as long as we are stuck in the rules that are now the conventional wisdom in Washington, that the federal government can't raise any more revenue without having dire effects on something, we're never going to be able to adequately protect Medicare and Social Security. We can't make the arithmetic work as the number of beneficiaries continues to increase. And, again, by international comparison, the United States is the only country that would try to do this in the sense of trying to spend all of these dollars on the military and so on, as well as on what remaining social benefits we have, without having a plausible fiscal strategy for generating the funds to pay for that. One last real quick story, if I can, Judy. In 1999, this issue sort of emerged, and I'm sure you all remember the famous National Bipartisan Commission on the Future of Medicare, which, whatever some Heritage Foundation and others have claimed, never actually even issued a report. But at one of its last meetings, prior to one of its last meetings, I gave a talk at the Brookings Institution, and I said that I was pessimistic about coming to agreement because the Democratic members of the commission had all agreed that there was no long-term, this is in 1999, there was no long-term financial solution to the problems of Medicare without increased revenues. And then I went from that Brookings thing to a meeting of the commission at the Russell Senate Office Building, and I'm sitting there in this meeting, and this is 1999 technology, and I see that all the administration folks who are sitting around the sides of the room, their beepers are going off, and their cell phones are buzzing. And I'd been in the government recently enough to know something big was going on at the White House, and they all go rushing out of the room to get their messages and so forth. And after this has been going on for 20, 25 minutes, somebody comes and taps me on the shoulder and says I need to talk to someone on the phone, and I walk out of the room and they hand me their cell phone, and there's somebody from the White House on the other end and said, the Ways and Means Committee has just issued a press release that you've floated a trial balloon for the administration's new tax increase for next year. I said, oh, and they said, you were at the Brookings Institution, you gave a talk? I said, yes, and you called for new taxes to pay for Medicare? And I said, well, I think I used revenues, not taxes. But I absolutely did, and so on and so forth. Well, everybody's all in a tizzy and da-da-da-da-da. I said, well, what do you want me to do? And he said, well, I don't know, we got to figure out what to do. I said, I'll tell you what to do. Say, the guy used to work for us, he no longer does, he lost his mind, or it's not our problem. And they said, no, we don't want to do that, we'll call you back. The conversations at the White House literally went on till very late that night, and I didn't get the result, but I was trying to behave and so forth. And so the next morning on my way into the hearing, the phone rings, and it's my source at the White House saying, well, we spent a lot of time trying to figure out what to do about your comments. And I said, okay. And he said, you know, and we finally decided, we're glad you did it. And I said, oh? And he said, because it's true. And I said, I didn't know that was a criterion. And he said, no, but, and it's good that you floated it and you surfaced it, so it's on the table and somebody's respected on the table, and we didn't have to say it. And I said, I'm always sort of glad to be of service. He said, I just have one request for you. And I said, okay, what's that? He said, in the future, when you talk about these issues, could you use the R word, not the T word? So I said, yeah, I get it. I'm sorry. I don't even remember whether I talked about revenues or taxes, but I know well enough. In the future, I'll just talk about the R word and so forth. End of discussion, except that night, I called my mother to tell her I had safely gotten back from Washington and sort of tell her the story because I knew she'd appreciate it. And I go through this whole story. And she says, I listen to it, she says, can I just ask you a question? I said, sure. She said, where does the government get R's other than from T? And I'd been in public service long enough, I knew the answer to that right away. I said, the lottery. Anyway, she said, well, maybe we can also all sort of collect our cans and bottles and cash them in and give the proceeds to Medicare and so forth. But so this, we've danced around this as the political winds have blown and diminished and so forth for a long time. In the current environment, particularly with the efforts that are coming this year to massively overhaul the Internal Revenue Code, we have to be more overt and open and explicit for it. If you're going to have a decent and humane society in this country, you're going to have to pay for it. And we have to figure out the most equitable and efficient way to do that. Thank you.
The bill that did not get voted on last week, amen for that, included a reduction in the R gratuitously for, I think, for Medicare, except for, we know, the plan was to destabilize Medicare, decimate Medicaid, which was gratuitous to have that in the repeal of the Affordable Care Act, really would have decimated Medicaid. And the bill, as we all know, had the reduction in the payroll tax that goes directly to Medicare for people, individuals making $200,000 and a couple making $250,000. What purpose was that put in to help buoy Medicare? And frankly, when it was in the Affordable Care Act, I expected, once it became effective, and I forget what year, but it wasn't immediate, to be at the town halls and senior centers speaking that we do and have a real hue and cry about it. But it never happened. And I think that's because they don't notice it. You know, a 0.09% increase on your payroll if you're making $200,000 or they didn't notice it. There was no, to my knowledge, and I think we would have known, there was no energy to get rid of that. And yet it would have destabilized Medicare and helped us be able to say that Medicare was going broke. So watch for that, folks. Also, in your folders, you do have a story form and a pad, by the way, if you want to take notes, and the agenda. And we are all about collecting stories. I think it really, the Voice of Medicare Summit, you know, we've gotten this for a long time, but we are collecting stories. Please get them to us. We will be back fighting to preserve health care. We will be watching to the best of our little abilities, but we know who to call on, Bob, to help understand what's in the tax quote reform. You know, the words reform, preserve, protect, secure, all those words have become very scary. They're like, frankly, if the speaker says he wants to preserve, protect, or save Medicare, I know it has to do with privatizing Medicare. So let's listen and have stories. Marilyn Moon, I wonder if you would, from a wonderful researcher and longtime Medicare expert, if you have anything to add to a question from the panel you've just heard. And Matthew has a mic for you. Thank you.
I don't have much to ask questions about because I really enjoyed the comments. I thought they were all right on target. I think Part D needs some real attention, and that's one where there might actually be a tiny little iota of bipartisanship that could come out of that. I applaud Bruce for talking about revenues. For a long time I've said I'm not elected to anything, so I can ask for higher revenues. But I was struck by the date that you were talking about. You remember that's when we actually balanced the budget, and we talked about having the problems of paying off the debt and some of the problems that could actually create in terms of financing. And it says a little something about how far we've come and how unwilling we've been to pay for what it is we get over time. My only other thought about this that I think might be useful is some of the things that really need correcting. One is the notion that we're the highest taxed nation in the world, which I hear periodically, and I would love to hear a drumbeat of people essentially putting that down and talking a little bit about what other countries do for their citizens in terms of what they pay and where it goes. I think some of that could help balance some of the discussion. And I also think that that the whole notion of somebody has to pay and putting this in the giant context. When people were criticizing CBO the other day, one of the things that really struck me is that the real legitimate criticism about CBO has to do with the constraints that it faces, and that is it's supposed to look only at government costs and benefits. It's pushed that envelope over the years and talked about society's costs to a certain extent, but it doesn't do it enough. And that's something we should all talk about, particularly when there are policies that simply shift costs from one sector to another, from government to the private sector. And one of the things that ought to be really important then to talk about is, yes, you can sound like you're saving government money, but somebody has to pay. And it's remarkable how just pointing that out sometimes causes people to say, oh, I guess that's right. It doesn't just go away. The problem doesn't just go away because the government isn't doing it. But I commend the panel. I think it's important to do some of the weeds kinds of issues that Bob was talking about, as well as the big picture issues, and I think we need to work on it on all fronts. Yeah. Thank you.
If I can just add one thing to that, and much as I hate in principle the idea of dedicated taxes, the fact of the matter is that to the extent it means anything in the political process, the public polling data for a generation has been very consistent that Americans are prepared to pay more taxes to support Medicare and Social Security. And again, we have to figure out how to, the problem is that the only mechanism we have at the moment that dedicates that to Medicare is a payroll tax, which is regressive. So, although it's less regressive than the other parts of FICA. So we have to figure out how to convert that into a strategy.
Thank you.
Is it on?
Yes.
Okay. One of the things that was very important in defeating the bill last week was that states and localities came forward and talked about how it was a cost shift to them. So they're also factored in. We've got the reporting on whether we're doing a mandate to them, but we don't have the reporting into what necessarily their costs are going to be. I do want to just underscore what Bruce said about taxes. In our office, if you come in and you ask for funding for something, you get a little discussion about why you need to be involved in raising revenues in tax reform. And I cannot tell you how many people look at me as if I have three heads. They don't want to have that debate, and they say, well, that's not what we do. We're here to ask for the money. And I said, well, if we don't have revenues, I can't help you. And it's people who keep coming back year after year get the same lecture, and they say, okay, we're going to get the lecture again. But we have to make it safe. This is about, it's not just about raising revenues, it's about the role of government. The two work together. But people have to be willing to wade into the tax debate and use the T word and go after it. I mean, on last week's bill, the top 400 families would have gotten an average $7 million a year tax cut out of that bill. There's a reason why they're doing it.
Is there anyone else on the panel who wants to weigh in? Tricia, did you?
First of all, I totally agree on this tax issue, and I think we need
Can you give her the mic just so everyone can hear, Tricia? Yeah, but
I completely agree that it is difficult to talk about revenues or taxes, but that we, looking at demographics, looking at human decency, we need to find a way to have these conversations and to think about framing so that the discussion can occur, because it needs to happen. It's not happening. And Marilyn, of course, did her part. I remember driving home and listening to her on the radio going, tax me, when she was talking about, which was so great. I have a question, if I can.
yes, please.
Which is a little bit down in the weeds, but I think may be useful to the audience. We have a lot of people here with experience in government. And I guess I'd like to ask anybody who wants to answer, what should this group expect? What should we be looking for the call letters coming out next week? What are the smaller, non-Medicare fundamental reform, revenue, congressionally required activities that one might anticipate that could still be important to people in the program? Could it come out of the Center for Medicare and Medicaid Innovations? Could it be by reg? Could it be in the call letter? What might we be looking for?
Sean.
Well, one of the ironies is, I've always said, of Medicare and American healthcare is we all love hospitals, but we're willing to underpay them, and we all hate insurance companies, but we're willing to overpay them. But so Medicare Advantage payment is supposed to be based on a formula and it's supposed to be very objective, but the truth is there are a number of dials that the administration can spin. There's dials that the plans themselves can spin on coding, but there's a number that the administration can do. And so I you know, if you see large increases, I think the table that came out with the draft rate notice was for a very small increase. If that goes up substantially for any reason other than the actuary changing the baseline, then you see that we're back in the world of being more than happy to overpay plans, which is just frustrating if, you know, if we have the programs growing double, you know, in the next 10 years to not get the efficiencies where you can fairly get them. That's the first thing that leaps to mind. I do think, you know, if this third way of saving money and improving care of alternative payment models is going to bear any fruit, I do think things like the mandatory bundles model that was recently postponed, it sort of signals a shackling of the Innovation Center. And I don't want to argue that the Innovation Center has gotten everything right, but I think bundles is a pretty safe alternative payment model and one that could yield pretty, you know, not a huge savings, but could generate savings. And the notion that none of those models should be mandatory on providers, I think, just means this whole alternative payment model thing is never really going to take off in any form either.
I want to pick up on Sean's first point, which I agree with. I would remind everybody of that line from Newt Gingrich from 20 years ago that Medicare will wither on the vine. I mean, the overt way is through premium support, which I think at least temporarily is in the back shelf. Even though Congressman Ryan would love to do it, I think Senator Alexander, Senator Hatch understand the bad politics of it, and they're not as committed. So with the failure of the repeal and replace, we're not facing it right now. But if you overpay the plans sort of systematically, beneficiaries move. And one of the political dynamics here is that there's really no stakeholder who's got a stake in saying the plans are overpaid. Virtually what you do. You're about the only, I mean, the beneficiary organizations like these are basically the only ones. When I was working at CMS in the job basically that Sean now had, I was hauled in mostly by Democratic legislators, like from Westchester County or from Broward County in Florida, who their constituents were watching TV ads from the Bronx and Manhattan and Miami-Dade County and saying, how come we don't get all those extra benefits that they're getting, sort of the next county over, and why are you sort of not being as generous? So so only in the context of the Affordable Care Act, with a major piece of legislation, was there discipline on the Democratic side to actually say, you know, the plans are getting overpaid, and that's how we can find a source of revenues for the coverage expansion. Left to normal activities, you really don't have anybody who's sort of watching the money that the plans get. And so the docs under MIPS, the losers are going to pay for the winners. They pay for performance. Those who do badly, I mean, I think the whole thing is silly, but I mean, it shouldn't be done, but it's budget neutral. MA plans, it's not budget neutral. Extra money is being paid for the star ratings. So that is one reason why the plans are overpaid. But the major reason is after 15 years, really, we can't get risk adjustment to work well enough to protect against the favorable selection that the plans have figured out how to get. And so there, I would argue, still substantial overpayments to Medicare Advantage plans that are not, that MedPAC doesn't really capture. But the political point is there's nobody shining a light on any of that. So to the extent that you want to do so, I'd be happy to help.
You're on. I just wrote down, Bob, MA are overpaid. We've been drumming this. I often say when it gets to budget issues, if this was really about money, we could deal with it, but it's not, because then we'd be dealing with Medicare Advantage overpayment, we'd be dealing with drug overpayment, and that discussion we could have. Bruce, and then we're gonna have to wrap up.
Just two quick things. Bob's comment, another very quick or condensed story. In 1995, Phil Lee, who was then the Deputy Secretary or Assistant Secretary for Health and Surgeon General, not only had his 70th birthday, but it was the 30th anniversary of his having served in the Johnson administration. And so we had various kinds of ceremonies to recognize it, and one of them, staff made a video based on the premise that 30 years from now, he'd be back again and celebrating his 100th birthday, and what would HHS be like in that time? And one of the scenes was filming, or somebody filming this CMS on the third floor, and somebody saying, who's the administrator now? And somebody saying, well, Vladek's still here. And somebody say, why? He's still here, why? And he said, well, he promised Pete Stark he wouldn't leave till he got risk adjustment right. So I can really relate to Bob's comment in that regard. But talking about the politics and its disconnection from reality, one of the things that has struck me in the last year or so, and that even though we were talking about the House, not the Senate, came up more than I might have expected in the recent follies about repeal and replace, was how much trouble healthcare providers in rural America are in these days. And for a whole variety, and what you were hearing, interestingly, is some of the Medicaid advocates getting to governors in red states and saying, your number one problem in your state at the moment is opioid use, and the only treatment services you have in the entire state are financed by Medicaid. And if you don't preserve the Medicaid coverage of these services, you have nothing. The fact of the matter is that most of us pay very little attention to the particular problems of rural beneficiaries, partially because there aren't that many of them, and we don't talk to them, and so on and so forth. But you know, thanks to the great Philadelphia Compromise, they have a disproportionate effect on Medicare policy, certainly in the Finance Committee, and the hidden secret about doing things to help residents of rural communities is that because there aren't that many of them, it's cheap in aggregate budget terms. So I think one of the things the advocacy community has to think about harder and more systematically is, first of all, connecting up to the relatively sparse network of rural advocates, and second, getting some of that explicitly on our improvements agenda, because again, that is a subset of beneficiaries who have very real needs and very real problems, whose political significance is way disproportionate to their actual numbers, and we've never really, I'm just speaking for myself, I think we've never really paid them enough attention. And so just another fine point as we think of the stories we're going to try to convey.
Thank you. Very wonderful panel. And in closing, I also want to mention that I was among, I think, two things that struck me among the most about the recent battle was the importance of stories and the importance of the CBO. And I never thought I'd be saying thank goodness for the CBO. But boy, you know, it was very clear we can't get anything, us guys, in because it's going to have a terrible score. And what's the pay for? So what was the score and what was the pay for? And we have to keep, when people cut taxes, what's the score and what's the pay for? Because cutting taxes is a cost. So anyway, I think we need to know both of those things. I'm going to have one question, and then we have so much. Well, you know what? In order to get a few questions, I'm going to reduce the break a little bit so we can do that. And Matt's going to kill me about that because the evaluations all said more networking time. But, okay, Lynn here, and then this lady back here. Dr. Mowden? And then this gentleman, and then we'll have three questions, and then because we are not going to shortchange the next panel about very much about real people.
So I'll try and make this quick. Thanks, Judy. I'm Lynn Mowden. I'm here on my own nickel because I think I can claim it as CME. But since I'm on the clock, I guess I can say I'm the Chief Dental Officer for CMS. So I actually, first of all, want to thank Kathy for mentioning dental. Thank you very much. We should talk more later. I actually want to repeat a question from last year when Sean was the administrator. And the conversation, we've had it with Judy and Weiwei and Bruce about medically necessary dental care being covered by Medicare. It should be. We have people that are in line for transplants or joint replacement that can't get those services because their oral health is so bad they can't participate in the surgery. So now, Sean, as an outsider with all the information, I want to know what is the likelihood and what do we do to get medically necessary dental care covered in Medicare?
As far as I could tell, it was entirely a statutory problem, and I mentioned this to you last year, that Medicare covers everything. We believe we covered everything that was allowable under the law. The other alternative, and I think Bruce led a group that suggested a CMMI demo. The problem with the pathway of doing a CMMI demo is it would be unlike every other benefit. Most benefits you get because you need. In a CMMI demo, it has to be a benefit you need, and it's going to save money, which is a pretty high hurdle. But I think when that idea was brought to the previous administration, it was near the end, and just the agenda was too full. I have no idea what the current administration's thoughts are. We thought it had merit. There's no hostility towards a dental benefit, and I think clinically it makes eminent sense. So the two pathways are statutory change, or if you're willing to live with the limitations of a CMMI demo, try to advocate for that.
Lucille Roybal Allard has a bill. Seniors have ears, eyes, and teeth. I think that's the name of it. It's got 129 co-sponsors in the House, so we're working on the statutory side.
Lady in the red?
Hi, my name's Betty. Thank you for all your work with Medicare. I really appreciate it. This is a quick question. Over this last year, or last few years as a patient advocate, I've been learning a lot, but there's so much more to learn. So this may be a very simple question. Sean, you mentioned that CMS hears maybe once a month about a beneficiary. How could an organization or a beneficiary set up a meeting with CMS to talk about issues, and who would they make a meeting with?
That's a good question. It's actually easier than it. The hard part is figuring out who you want to meet with. The easy part is getting the meeting. I tell people this all the time, and I was at CMS for 6 years, and to the best of my recollection, I only turned down 2 meetings, and both cases because there was litigation pending. And so I always said, if you're going to sue, meet first, then sue. But there are groups, and I hate to do this. Oh, she left, so I can't. So there's groups like the Kaiser Family Foundation and Tricia Newman who know the bureaucracy well and can help steer you in the right direction based on whatever issue you're talking about. But I think that's the hard part, is figuring out where you want to be in the bureaucracy. Once you know, a simple call. All the emails of CMS staff are publicly available on the HHS locator. You can get their phone number, their email, and just reach out and explain, this is who I am, this is what I want to talk about, this is when I'll be in town, and I think you'll find them accommodating. Doesn't mean they'll do whatever you want, but they'll certainly listen. And this is my brief chance to make a pitch for, I got the opportunity to work at CMS for 6 years, and I just want to say, I know it can be frustrating for outsiders. I used to work in a hospital. I found working with CMS frustrating. But I have to say, the frustrations largely stem from the restrictions CMS operates under. The people themselves are incredibly dedicated and knowledgeable civil servants who operate under very difficult circumstances. So I think they'd love to hear from you. They're good people, and I encourage you to do it.
I think that's absolutely right. Bruce?
I just have one other long-standing bone to pick. I think you will find folks at CMS remarkably accessible, except for the fact of the most ridiculous level of nuclear level security at the CMS headquarters that I
Go
have
to
never
HHS
figured out
building in
why
DC.
what people are going to steal when they get there, because all the data is stored off-site anyway. So but that's my own little hot.
The gentleman here on the left.
I do
Bob,
a
yes.
real quick. A related issue is, and this I'm reflecting on my CMS experience, public rulemaking. Typically, the interest group that wants the rule done in their way will comment. It's a public process. There's usually 60 days for comments. Rarely do beneficiaries sort of have the skill knowledge to actually participate in that. So my thing that I've been trying to do for 20 years unsuccessfully is to rebalance the Medicare fee schedule to pay less for a whole series of minor procedures and pay more for time. The only one who ever sends comments in are those who have an interest in keeping the status quo for the most part. So I don't think a beneficiary group can come in and say, we just think you should redo the fee schedule, although that's probably helpful. But to the extent that beneficiary organizations can get engaged with the kind of detail that's necessary so that the CMS staff say, wait a second, we actually have alternative views that we can then provide more of a basis to kind of make the changes we think should be made, but we have nobody commenting.
And
So
that
I'm
is
just
a
saying
place
there's a
we
real
really
opportunity.
try, and our allied organizations shaking their head, NCOA, families, MRC, community college.
Yeah,
It's
no.
absolutely true. And we try and share resources to write and sign on or vary a little bit so there'll be an extra count. But I think what Bob's
but I
saying
think to some
really
extent
true.
you got to be willing to hire the same sort of consultants that the providers hire to do that kind of analysis to get in with those
Able
kinds
to
of
hire.
details.
Yes,
That's
thank
what
you.
that's what I'm suggesting.
Kathy?
Yeah, I just also wanted to say, don't forget members of Congress who are your allies. We're paying a lot more attention to regulatory issues these days. But also, I know that we worked with Toby to get language in the ACA on nursing home protections. And the administration was really slow walking it for a number of different reasons. And we were able to, on the inside, have meetings with CMS to push them. So look for allies in Congress, too.
And one more question. Thank you. That's absolutely true.
Good morning. I'm Jerry Rothkopf. I'm in private elder law practice in Cherry Hill, New Jersey with Rothkopf Law Group. I just want to touch upon, I have a comment and a question based upon what was previously said. First of all, I think she's left the room. She talked about comparisons with healthcare systems in other countries, and I think you talked about the situation in Northern Europe. I was privileged to be part of an elder law delegation who spent a week in the Netherlands in November, and we studied the healthcare system specifically related to long-term care system. And we went to a long-term care community called the Dementia Village, which some of you may have heard of, outside in the suburbs of Amsterdam. And in the Netherlands, they pay much higher taxes than we do, as was previously mentioned. And it's from the long-term care perspective, it's no issue. Everyone's covered. It's done very humanely, and it's compared to our long-term care system. We have much to learn from the Netherlands. And number two, Dr. Berenson, I have a question for you related to Medicare reimbursement based upon value and outcomes. And I just want to drill down specifically for an example with hospital readmission penalties. And you talked about the data or lack of data, and and you criticized the use of that data. So, but is there data related upon hospital readmission penalties to show it improved outcomes? The outcome, I'm assuming, to change behavior based upon adequate discharge planning, or could the panel address, or should we simply create reimbursement for adequate discharge planning to begin with, to create safer outcomes, which will reduce potential admissions to long-term care facilities, so people know how to take their prescriptions, they know how to handle durable medical equipment, and they know when to call the doctor and follow up on doctor's appointments. So I was wondering if the panel can comment on those issues.
We'll have one response because of time, but Jerry, I think you've hit on a whole panel about readmissions. Are they real? Are they not? Could they be addressed? Where does observation come in? What could we do better about discharge planning? Is there a comment?
Well, this is a very interesting and complex topic. The argument is that when you have real financial incentives, you will get a behavior that you don't get simply by saying we'll pay for discharge planning. Actually, it's sort of assumed in conditions of participation and other things that discharge planning is going on. When you actually put some dollars and cents behind it, maybe it would be more effective. Having said that, there is now a readmission penalty that hospitals want to avoid. However, hospitals that do a really good job at reducing readmissions also reduce admissions, produce a better outcome all across the board, but wind up losing money. And a lot of chief financial officers say, why are we doing this? Why are we going to actually reduce readmission? The penalty isn't worth the the value of all those admissions that are not coming in. So it's sort of a tough balancing act. In fact, the UK and Germany, in their DRG payment structure, actually don't pay for a readmission for a new diagnosis or for a complication within 30 days or whatever those rules. There are many different ways to address it. I guess the basic issue that has the sort of upper hand in the debate right now is that you need to have financial incentives to get people to do the right thing. And I think the sort of evidence is somewhat mixed on that, but that seems to be what's animating the current policy. I believe, having said all of those caveats, that there has been a reduction in readmissions, partly attributable to the fact that there's now financial penalties for readmissions, that the readmission rate has come down somewhat.
Yes.
Although there's a lot of concerns about the accuracy of that measure. And I'll finish this point. Some organizations that do a great job of reducing readmissions, if you do the calculation, what happens? They reduce readmissions, they're also reducing admissions. In other words, after the 30 days, there's unnecessary admissions that are reduced. Their ratio doesn't change. It looks like their readmission rate is the same. In fact, they have reduced, they've done a terrific job. So it's just another example where measurement can be misleading. It's complicated.
Thank you. I am going to thank you all. You can see the interest in what you all just had to say. Thank you so very much.